And Tasneem was actually shortly touching on one of the issues of why CIMT has been such a parameter which in some studies worked and other studies did not work. And you just need to understand that if you take a picture using high-resolution ultrasound, it's like a camera. You focus your lens, and then you see the sharpest part of the image, but the depth of the image is actually not very great. And in fact, if you take an ultrasound transducer and scan in the long axis, this is what it looks like in the short axis because of the focus. You're only going to see a slice that is probably 1 to 2 millimeters thick of the carotid. So think that if you're looking for measuring IMT, you're actually only seeing part of the circumference of the vessel. And if you then furthermore limit your study to only studying 10 millimeters of common carotid artery, no wonder that IMT missed a lot of stuff. And you see that's illustrated in this slide here. I think that point here. So if you happen to have your transducer there, you would measure erroneously this plaque as IMT thickness, but if you measured here, you would have very thin IMT. So again, if you were looking with IMT there, you wouldn't find anything, but if you measured the plaque, you would find something. So really, IMT is, I don't know, in my mind, it's crap. You know, but there are other words for it, depending on how you measure it. Plaque is really the disease, and as our good friend Henrik Sillesen used to say, nobody dies of thickened IMT, but they die of plaque rupture. Right? So anyway, so this is small plaques and larger plaques. And the whole idea of introducing plaque is that it's turned out that just the mere presence apparently increases the risk typically about a factor of 2. And as I'm going to show you, there's been introduced several ways of quantifying plaque area. Rehab stenosis is something we've done for many years before operating. Plaque burden, plaque volume, just these things. So just looking at plaque presence, and Tasneem already showed these data from the ERIC study that showed when you simply added the plaque presence or absence, you kind of doubled the risk. Skip that. And this is from the framing offspring, showed exactly the same, that if you had plaque, you fared worse. And I think this is from the MESA. If you look at the top left, adding plaque would double the risk also. So there's no doubt that having plaque in carotids is bad news. Some people then thought, well, you know, sometimes plaques look big, sometimes they look small. What if we simply measure the area in a 2D image, which would be kind of a pseudo measure? It's not a real quantification in the sense that it's 3D, because you can actually make the plaque look larger and smaller depending on how you scan the scan angle. But still, if it looked big, it might imply something. And this is the first work that was done by a neurologist called David Spence, who did it in, you see in the top left how he outlined the plaque in this longitudinal image. And he just looked at the area and plotted the 4 quartiles of area to risk of having a new cardiovascular event, and that seemed to work. And this was also done in the Norwegian population study, the Tromsø study of 6,000 to 7,000 people, and they found exactly the same thing. The higher the area of the carotid plaque, the higher the risk of MI, and I think the top panel is women and the lowest is men. What about degree of stenosis? Well, we've known for a long time that if you have carotid stenosis, you have a high risk of having NMI. We still discuss the risk of stroke, and where I come from, where we don't make money per procedure, we don't treat asymptomatic carotids interventionally. They get good drugs, good medical treatment, no operations. And I try to make the point, even to intervention cardiologists over here, that they shouldn't have a stent. That's a hard job over here to tell them that, especially when you tell them that there's no evidence for doing it, and they look at you like you're an idiot. There is no evidence to stent carotids, just to make that point. But anyway, you can actually use degree of stenosis as a risk predictor for future cardiovascular events. And just to remind everybody, if you do want to quantify degree of stenosis, we have to do that in Doppler, not with beam imaging. So we look at velocity increases, and I'll get back to that in a minute. So I'm going to show some data from the Highway study. Some of you probably thought you heard enough about it. Just to remind everybody that we had 6,100 that underwent multi-modality imaging, including ultrasound and CATs. And we also scanned them looking for carotid stenosis, so they all had Doppler of both carotids. And as you notice from this slide, you see we had 1,100 without any disease. Those were the 22%, of course, without plaque. Then we had 4,500 that had some kind of plaque, below 50%. And then we had 349 that had true carotid stenosis. And if you look at the cardiovascular outcome in those groups. It is as expected that if you have carotid stenosis, your risk is almost 3 times as high than if you have no plaque. And you have these moderate or minor stenosis in the middle. I didn't bring the slide that shows the stroke risk, because that's very interesting. We had 8 strokes, 4 in people with stenosis and 4 in people without stenosis. And that's actually very interesting. So there's no case for intervention, at least in this group, with stent or surgery.
Excuse me, Henrik, it was fatal and non-fatal MI?
Yeah.
Fatal and non-fatal stroke.
So it was cardiovascular, primary endpoint was cardiovascular death, MI, stroke, and relapse. And then secondary endpoint included alcohol mortality, and I think unstable angina. So plaque burden, that was the new development for that we did in the high-risk plaque study. I won't say we invented this cross-sectional sweep, but I think we were first to put it into a system. And the whole idea was to have some way of scanning the whole carotid, not just be looking at focal points, but kind of say, we're going to look for disease everywhere. And the easiest way is to have your transducer in cross-sectional mode just above the clavicle and move it up to the jaw. And we kind of defined that you can actually do that movement in 10 seconds. So on everybody, we recorded a 10-second video, which we turned cross-sectional sweep. And it actually, it's very small on my screen, but if I can actually hit the button here, I can show this video. For some reason, it's done so small. Oh, I can't make it work. Oh, I can see that right there. Oh, there it is. So here you see we move it up along the neck, and now you see the plaque develop there. Got a bifurcation. And that's it. So this was then analyzed. We did this to kind of have a pseudo or manual 3D representation of carotid because we didn't have 3D ultrasound at that time. We did it to have an overview of carotid artery, and also as documentation of the scan results. So, if the stenographer had not identified disease, we can actually afterward check it. Now, the way we read it was, as you would read anything in 3 dimensions, that we looked through that. We had this software which could identify the borders of the carotid artery, and when we had plaque, the plaque was outlined. And all these plaque areas in each of these images were summarized into a number. And then we took this number from both sides of the carotid and we termed that carotid plaque burden. And if you plot that to these major adverse cardiovascular events, you get something like this, that if you have a lot of disease, which is the orange on top, you have a higher risk, and you have intermediate, low intermediate, and no disease down here. So these 3 are simply tertiles. We could have done it different, but these are simply tertiles. And the white one is no disease. And if you put that up in a forest plot like this, and you adjust for all the cardiovascular risk factors, which is the kind of the 3rd panel down here. Here it's adjusted for all kind of disease. You can notice that those with little disease actually did not have significantly higher risk than those without disease. And again, that comes back to the point that we had 78% with some kind of detectable plaque in these, on average, 69-year-old people. And it just tells us that we all do get some kind of plaque, and it's probably not that bad as long as it's not very much. And then you're absolutely right in that we don't have that algorithm for ultrasound, and we're going to need that in order to be able to use this information. But on the other hand, if you had if you're among the 1/3 with a lot of plaque, you clearly had a lot higher risk. And I think it's interesting to compare with CAT scores up here, which use the generally accepted classification. There's quite a lot of similarity if you look at those hazard ratios. So the point I'm making is that this tool can be developed to something which is as potent as coronary calcium is, and without the backdrop of being a big machine using X-ray.
Do you have the corresponding plaque area numbers to the corresponding CAT numbers in your tertiles?
Yeah, I have them, but I can find them. I don't have them in slides. Yeah. Now, the problem with this plaque burden number is that it's an arbitrary number, and it depends on the speed you actually move your transducer. And that was done by a stenographer. And obviously, they did not use the same speed all the time, even though scanning all these people, 12,000 carotids, they got quite used to it. So this number is not a good number that you could use for repeated scanning. But it just gives you an idea that when you try to make a quantification, it certainly shows similar things that you find with.
Can you answer the question Jessica asked Tasneem, that those people with no plaque in carotid ultrasound, but had significant coronary?
Yeah, I got a plot of that I can show at the end. Yeah, it's not in here, but I have it at the end of the slide there.
Can I also ask you the approximate time to calculate this plaque burden?
So,
and I presume it's much more than getting the estimated stenosis.
Exactly. So the plaque burden took us on average 20 minutes per case offline. Now that's a matter of the software we had developed to help us with. It was not very good, but still, this will always be a semi-automatic because ultrasound is a technique where you have artifacts and you need a human eye to see what's an artifact and not an artifact. So it's always going to be something that is going to be humanly assisted, and it's not anywhere near something that's on the machine that you can do fast.
And have you tried to kind of put that actually plaque burden head to head with the estimated percent stenosis? Does it really provide an added incremental information beyond the estimated percent stenosis?
I mean, you can take that slice that shows the most severe degree of stenosis because it calculates that as well, and then you get a measure for stenosis. But if anybody who knows a little bit about ultrasound knows that the more severe disease, the more artifacts. So it's actually not very accurate in predicting degree of stenosis. Doppler still remains probably the most important. But anyway, I'm going to get to a more simple way of doing things than what we did here. Just to show the NRIs for different low, intermediate, and high risk. And the most important thing is that it was comparable to CATs, what we did. Now, a very simple technique is simply measuring the thickness of the plaque. And we just recently analyzed, and I'm going to show you some unpublished data. And so you can see here, you see one of these slices, and the software automatically detected the outline of the plaque, and you can see we measure the thickness here. We have to do it radially. That's why the short axis is nice to do it. So actually this cross-sectional sweep holds all the data you need to find the image with the thickest plaque, and the computer software will do that very quickly. So here you see the plot, and this is for the primary endpoint. You see these here are the tertiles with the thickest plaques, and you see those with the thinnest plaque down here. And this here is max plaque thickness, so if you had plaques on both sides, we would select one with the maximum plaque. Down here we took the sum if you had more than one plaque on each side, and then it looks like that. And if we look at the secondary endpoints, it looks like this. So it's very, very simple. It actually looks more or less the same as the plaque burden graph, and it's almost as robust when you look at the statistics. I think they're coming here. So here you see the hazard ratios and what's called, this is for maximum plaque thickness, primary endpoint. Model 2 is correction for all the risk factors, and you see we come up with the risk, increased risk of 2. And if you look at the the sum down here, it's something similar. If you look at secondary endpoints, the hazard goes up, but it's still very similar. And finally, I just thought that we actually did IMT in HRP also. We haven't published those data yet. If you look at IMT, look at the risk for IMT, notice that once we begin to correct for risk factors, the significance of that hazard ratio goes away, indicating that simple IMT is not as good as other plaque measures, which I think both Tasneem and I always knew, but a lot of people would not be happy with that.
Can you comment on maybe just tertile 1 for IMT and the PT max there's actually a reduction? Is that so their hazard ratio is 0.8588? Is that just a statistical fluke, or do you think it's a biologic reality?
No, it's not a biological reality. No, that's a statistical condition. But it just shows that compared to plaque thickness, IMT is really weak. You see a relationship, no doubt there's a relationship, but once you get it correct for it, it kind of disappears. And we've seen that in other big population-based studies, especially the European study, the CAPS study showed exactly the same. Predicted for groups of people, but once you began to correct for all the risk factors, it went away. So in just the NRIs, again, you can see the NRIs for this order of magnitude for the whole group, not just intermediate risk, but for the whole group, around 20%. What about plaque volume? Now that's the goal for all this, because once you've got true 3D, you can probably be calculating more accurate numbers. The problem with the technology is it's taken longer to develop it. It's not there yet. Philips has one machine out in the world that can actually do it now. It's in Copenhagen. But I can't show it, and it's nowhere near ready for anything the first 2 years from now.
Another 2 years from now?
Well, they had told me one.
Well,
You know, in 2009 when we were here, it was 2 years.
well, we did get some 3D, but that was not very good 3D.
I know.
Now it's getting it. So anyway, people have done it. People have used it. This actually exists, and this is actually a Philips product. The problem with it is that it has a curved surface, and things with curved surfaces make not too optimal images. But anyway, some people have used it, and this guy, Dr. Yori, looked at it and compared 2D and 3D ultrasound to an angiographic score from people who have had curved catheterization, and found that it was much more reproducible looking at plaque volume than using the 2D estimates. And there's been some pioneers who have been using some homemade equipment who have also shown that that if you look at plaque progression and plaque regression, there seems also to be a relationship with outcomes, but this is in small groups. So it's kind of more like proof of concept than it's really true data. So getting to the end of this long talk, in my mind, IMT is crap. Put that into several review papers, but that's my perspective. Plaque, yes or no, is very simple. It works, but I think it can be done better because a lot of people have very small plaques which are not necessarily meaningful to consider. So plaque and yes or no will be too simple, especially in an aging population. So plaque area works, but I think that now we've got better methods. We should use that. Plaque burden, for certain, we have shown work, but it's time consuming. Plaque thickness, I think that's probably the way to go now. You can use it on any machine. You can teach any, I could say a monkey, but any vascular technician, anybody who can do echo can be.
IMT is crap.
Yeah.
They didn't like the monkey.
So I think plaque thickness.
Or still sweeping.
We do both, but we got this. Actually, I have one slide. Here. But here you see the potential of what you can do if you got a 3D system is that you can dual planes in imaging at the same time. And
may I have your attention, please? May I have your attention, please? We have investigated the source of the alarm and determined it to be a false alarm. Once again, we have determined it to be a false alarm. We apologize for any inconvenience.
That was IMT. Poor sensitivity.
No.
May I have your attention, please?
CNC of 0. That's why
We have investigated the source of the alarm and determined it to be a false alarm. Once again, we have determined it to be a false alarm. We apologize for any inconvenience.
I wonder if it's finished now.
Imagine you were on a statin for a whole 10 years and it was false alarm.
So this is what we're waiting for. It's very exciting and it looks beautiful. One of them Copenhagen can see it, but it's not ready for this trial. So anyway, the state of the art of ultrasound is it's ready for use, cheap and harmless, well documented, it works, it's repeatable. We can see early disease earlier than when you see it in cats. 3 days in development, the potential is great.
So if we were to have a trial, that would not be reproducible in another lab?
Well, I mean, I'm quite sure that if we were to have a trial running here, by the time that trial would start, I would think that we would be able to get some of that before that trial.
As a core lab? A few core labs?
Yes, in select centers.
But there would be such a great interest in having this tested if we could add it to a trial, and that would also maybe help for sponsorship, having not said anything else than that potential.
So I think one of the great benefits of IMT over the years has been its ability to track atherosclerosis over time and correlated with more therapies, thanks to people in this room,
Exactly.
than all of the other imaging modalities combined. Do we have that? I mean, you say it's correlation with progression, regression of disease, but we don't have interventional trials yet.
No,
of any
not
type,
really.
even observations on statins or observations on ACE inhibitors?
So, I mean, all statins and newer drugs have been in the development phase through an IMT study, and more or less all of them has shown the same thing, that the development of IMT apparently gets halted in the statin group, right? If you got enough cases. So that way you overcome the weakness of IMT if you include enough cases. But if you do a study like 500, put one group on placebo, the other one on statin, you will see IMT grow slower or stop growing.
But what about 3D plaque?
Well, 3D plaque would be better, but there's almost no data. There's some series of 50 patients which are hard to believe.
But you
it
know,
works.
David Spence, when he was here.
But again, I'll tell you, those series are so small,
Yeah.
it's about to be a believer.
Right.
I wouldn't show them because I think they're too small, but they're kind of proof of concept, you know.
Well, this is the Meteor data, which is 800 patient study, and
Yeah.
you can actually show regression of the common carotid maximum IMT on rosuvastatin 40.
Right.
But-
No,
but
IMT
this is
has
not
data,
that. This is
but
not
not,
that.
this is different.
Correct.
I know IMT, I know there's a lot of IMT.
But I'll tell you what,
Secure,
but
ASAP.
we got to forget IMT here because IMT has been proven it's not repeatable. That's kind of
It's
not
not
repeatable for
individual
in the individual case.
Well, but I think it's very useful in clinical trials for over
Yes.
time. We have a lot of this data that correlates
Yes.
with every possible
That's right.
good intervention we've tried. It works with IMT.
Diabetes,
So,
diabetes, hypertension.
yeah, I mean, a lot
That's
of
true.
things, right?
But plaque imaging has the potential to work on an individual basis.
And shorten the sample
Which is what we want to
size.
do, just like CATs, right? So that's why we need to develop for CATs. And that's why I also suggest that if we have ultrasound, we want to have multiple acquisitions during the trial. For instance, every year. And I would suggest, as it's said simply there, that we will require these sweeps of the carotid and the femorals. And we would use the 2D, I suggested, with plaque thickness. And if we could piggyback 3D on it, that would be brilliant.
So me?
No, I was just going to say that I would sort of take a little exception to the whole carotid IMT business for clinical trials, because that sort of was during the phase where we still were interested in the whole surrogate market business. I think a lot of the pharma industry has moved away from that because that data has not always been concordant, enhanced at all. And I think from that perspective, it's very difficult now to plug in a 3D plaque proposition for any study. I mean, most of the new lipid studies, if at all, are willing to do a post-MRI based study because that's at least extremely accurate. I don't think they're willing, for the sake of science, unfortunately, to invest in this kind of modality which has sort of variability, and I think IRIS had large standard errors. It's sort of like it's very interesting to us as academics, but from the pharmaceutical point of view, it's just not necessarily useful from the outcome perspective.
But for our discussion, this is not going to be an outcome. It's going to be a tool that we're
They're
going
gonna
to
use it to
evaluate
make the
it
decision.
versus
Right.
the outcome.
I'm just saying that, when we talk about accumulating 3D plaque and event data, the problem is for intervention trials is that becoming difficult to plug these in as sub-studies because there isn't an interest in funding these from the pharmaceutical perspective. I mean, they're couched in our studies, and we can probably look at effects related to intervention versus not.
I mean, it's
But
not an
there
accepted
is
surrogate.
No, but there is a great interest from manufacturers of ultrasound companies because they see the idea of having ultrasound as an add to monitoring of treatment. Rather than we still believe that blood test is a good way of monitoring treatment, I believe that seeing regression in disease is much more important than seeing low blood cholesterol or any other treatment. Now, we're not at a stage where that has been proven, but any logical thinking would say that would be.
I think that's a great place where you distinguish it from CAT, because we know that you don't get regression. Calcium is not going to go anywhere. It's going to be a stop.
And we may not even get regression, but if we see stop or progression, that's fine. That would be great. And if you could see that on a certain therapy, or if you treat to target or whatever you would call
Yeah,
it,
but
once you
the
got it,
problem
and it still progress, you've got a problem.
Yeah, problem is we don't really have standards or normal trajectories for progression of carotid
No, I know.
plaque, and so that's my personal bias is where we look at function. We need to look at vascular function. That function changes in weeks, in days and weeks versus years and decades.
Sure.
And so validate that along with the structure is what we need to focus on.
And are there other large cohort studies outside of bioimage that are using this modality yet? No, so it's still just going to be one study at this point.
But
Or
I think-
was- we need to
Well,
expand
sorry,
it.
that's not true.
No,
There's the PISA study in Spain.
So
Sorry.
PISA has almost 4,000 plus patients who are being image. We've already gone through 2 rounds of imaging, and they're going to have another one in a year and a half. So we'll have accumulated between that, and we're going to do a follow-up imaging for the image population with ultrasound. So cumulatively, we will have access to nearly 10,000 patients and in excess of 5 years of follow-up.
The challenge with the PACER study is the age of the group, right? So they are fairly young. I think they're in the 40s on average.
So they are about
So even though they're going to be
44.
followed for 9 years, there's not going to be many events probably.
So I'd just like to remind the audience about the lesson to be learned from using IMT in clinical trials. One is the enhance and arbiter 3. Arbiter 3 saying that myosin trumps ezetimibe. And when we do the trials, aim high, and we do the HBS2 3 thrive, we get either a null result or a potential signal of harm with niacin in the latter study.
Yes, IMT was
So
positive.
your caveats about IMT or other imaging tools looking at arteriosclerosis are well-founded. I mean, I was interested in your question, Jessica. Why did you ask that question about the pathobiology of carotid arteriosclerosis versus coronary atherosclerosis?
Yeah, and so I'll get to that piece second, because I want to second the comments that you're making, because the inverse is also true with the LPPLA2 inhibitors, where it looked like there was a signal, and then there wasn't a reduction in hard cardiovascular endpoints. And so it's obviously a much larger question, but how do we integrate the atherosclerosis versus the acute coronary syndrome, which is what you started off years ago doing, but I have the same reservations around IMT. The reason I asked is, what prompted me to think about it is we were talking about a strategy, right? So you come up with some imaging diagnostic, you stratify people, and then you treat them, and we had talked about aspirin and statin, for example, as a package or a polypill. And what got me thinking about the discordance is, are we actually dealing with different types of diseases, and should we be treating them differently? And so do we need to subphenotype? And I just got particularly intrigued. If one modality normally picks up much later stage disease, who are the people who are being picked up, not by CAG, but some of the imaging modalities? And is it the paradigm of treatment just very different for those patients? So that was the origin of the question.
Yeah. I mean, I believe in that. I think the targeted therapies are the way to go with clinical trials. And if you do carotid IMT, where the pathobiology of arteriosclerosis is different than coronary atherosclerosis, then if you have a treatment that targets atherosclerosis on the basis of arteriosclerotic measurement, we may not meet the endpoints.
Yeah, and to take it a step further, we also, I think, learned the lesson a very hard way by combining patients with cerebrovascular disease, cardiovascular, or coronary disease, and peripheral vascular disease. And so it's just being really careful when we think about treating.
But also, Sanjay, whenever IMT studies have actually looked at maximum IMT thickness, which is what they did in the Meteor study, where the suvastatin showed lack of progression or regression in some areas, they invariably moved away from measuring IMT, so they were now measuring plaque. Because maximum IMT is invariably going to be a plaque site in an individual patient, you know. So, and then this, the torcetrapib study, which failed, and we found out there were some side effects. It led to like hypertension, increased blood pressure, and that was one of the reasons the IMT did not regress. Is again the effect of hypertension on the medial hypertrophy that IMT is measuring. So every way you look at it, whenever you've combined IMT with indirect measures of plaque, you have succeeded, and when you've not, it has come back.
Right. I mean, I think the point, the general point, is quite valid, and I think it should be factored into the trial design.
Right.
If you're looking at two different entities, your therapies need to be targeted at two different entities. Blood pressure here, statins here, or aspirin here.
One more thing, I think just to clarify, because this is my understanding, is when you talk about the reproducibility, I understand there is a automated 2D screen protocol, at least on the Panasonic machine, it's not the Philips. Just wanted you to comment on that. You know, it's not, we have moved a step further from the manual. Is that incorrect, my understanding? I'm operational piece on these studies, so that's what I understood. I just wanted to understand if that truly is the case, because that would lend itself to a little bit better reproducibility than true.
So it's true that there is, as I told you, there is this 3D transducer that we also used in HRP for 4,000 applications. That's been used in all the PESA patients. The problem with that transducer, and then there's no, in good cases, that is very reproducible. The problem is that not all cases are good cases, and that's why we abandoned that transducer. It's not good for all cases. So the answer is yes, it's more reproducible with that, but no, it doesn't work for everybody. So we are still left with the manual suite. And again, I would just like to say the nice thing about the manual suite is you've got documentation for the whole lesson, because you wouldn't do that with any other study.
Yeah, but the problem is you can't just get it widely spread and it's operator dependent. The operator dependency.
You're always going to have that with ultrasound.
Yeah.
Period. You're never going to have an idiot-proof ultrasound machine. You're going to have something that is getting close to it, but you're always going to need someone who can tell, is this an artifact, is it not an artifact? If the automation fails, etc. You're always going to need that. But it's not difficult. You can teach people to do it. So it's not that bad.
Okay.
So I was just going to show you, no, wait a minute. I was just going to show you this. So this is the view from my condo. My wife and I just entered the third stage of life with no kids. So now we live in a condo. And you can see this is taken, this waiter. And I began a new hobby, which is in addition to my statin, and that is actually dipping in the cold water. So this is from February. And so as you can see, I suggest this is part of best medical treatment.
I think compliance will be low.
Thank you very much.
So now Robert Spurko is going to present on genetics? No, on proteomics?
Just a few random.
Robert